So Assalamu alaikum, and it's a difficult topic for everybody. But what we're going to do is not remember and memorize everything. But what we're going to do is how, if we have a brachial plexus case in the exam, how we're going to tackle it. Okay, and the easiest thing to tackle it is to assess the patient according to roots, according to divisions, according to the chord, according to the branches. Okay, so we need to know how to start. So they used to make you draw brachial plexus, but not anymore because there's no theory paper anymore. Like, okay, so we'll skip all that, but you must remember this. Each to drink called beer, roots, trunk, division, chords, and branches, yeah? And it's C5T1. Sometimes it's prefixed, sometimes it's okay? So mostly it is prefixed, but occasionally it's postfixed. Very, like I said, very, very rare. Okay, these are all the branches. If you look at the prefixed one, this is what it will look like. You'll have a C4 branch to it. And if you look at the postfixed, there's a T2 branch to it. It does not unite anything here, but come and give a branch later on into the division. Okay, so we'll skip that. This is how you used to draw a brachial plexus, where you do two Y's and one way, the third Y in the middle, and then join with two E's. And then the easiest way to remember this is both the seniors give a branch to the junior, but the junior decides to give a branch to the most senior one. Okay, so there's branches going up and down, but that's something you have to remember. Okay, you must remember that near the roots you have the nerve to the long thoracics, which is important. We need to know that, and also in the division part of it, there's a branch that comes out to the rotator cuff, and that's important to know in the future, because if we have to have our lost functions, we have to use that to get some movements and function as a salvage procedure. Okay, so the most important thing in the exam is you will get this as a long or a short case. Okay, and you need to understand anatomy to salvage yourself. You need to protect yourself, and you need to know what you have to talk. And the most important thing is, before you do anything, you need to know if the person that you're seeing has any scars or not. Okay, because in the exam, most of the patients that you will see will either have had surgery or are waiting for surgery. Okay, so I will show you two pictures. So look at this picture here. Can anybody tell me what is happening to this picture? If you were going to ask to see a patient like that, what is very, very important that you have to understand?
Scar mark at the anterior aspect of shoulder and the wasting of the forearm and the hand.
So this is a post-traumatic patient
Shoulder.
Who already has had some surgery. Okay, so this is the exploration of the brachial plexus scar. Yeah, what scar is this? What scar is this?
So for the intercostal nerve graft.
So it's one of the
nerve transfer.
Yes. So you must see these patients in the exam, and you must remember what other scars to look at. In this patient, all you see is a brachial plexus exploration scar, but in this one, not only has he got an exploration, but they've actually used nerves from the intercostal nerves to transfer. And I'll tell you later on why.
Yes.
Okay? So it's important to describe what you see. Okay, so most important thing.
I want to comment.
So, yeah.
Shabazz here.
Yeah.
So whenever the candidates are describing any picture, specifically the picture which is given in the slide, can you please show us? So first of all, comment on the attitude of the limb. So this limb is actually internally rotated and adducted. So that is the most important, that this patient is still having, or it can have adduction contracture or internal rotation contracture, which is very important in brachial plexus examination. So always comment on attitude of the limb and then describe the scar or whatever is present. That is essential in the exam.
And very good. But we were going to come to that. I just wanted to make sure not to miss out the additional scars that you see. And you're absolutely correct. You need to make sure what posture and attitude the limb is, because that is not a normal posture of the limb. And if you look at the surgical brachial plexus injuries, this is also unusual. This is a post-correction posture when something has been done for
exactly.
Yeah, so you must understand that this is a post corrective scar. So the most important thing is, if you look at the person first, when he's given to you the short case, you need to have a look at the hand. Okay, first thing you look at the hand is the hand a good hand or a poor hand? If it's a good hand, then it is a partial palsy, and if it's a poor hand, that means the hand has got various contractions, then it's a very, very total kind of. So it means either it's an inferior part of the brachial plexus injured, or it's a complete injury. So, okay, and a total flail hand that doesn't do anything at all represents a complete a brachial plexus injury. Okay, so this is before you have actually comment on, and the description of the patient depends on how you present yourself, because if the examiner is not looking at a diagnosis, everybody knows it's a brachial plexus injury. Okay, and everybody knows what branches are gone. What they're trying to look at is how structured you are and how you come to a decision and a conclusion. Okay, so the first thing to do is to look at the person's hand and see whether the hand is a good hand or a poor hand. Okay, that's the most important bit. And a totally flail arm will tell you that everything is not working. Okay, so the simplest thing to look at a hand to begin with is we'll give you whether it's an upper or lower trunk palsy. Okay, so a clawing hand will give you a lower trunk palsy, and a weighted tip arm will give you a upper trunk palsy. Yeah? So this is just a starting thing, but we will go to that. Okay, so the most important thing in the exam is the first thing is to decide whether it's a pre-ganglionic or a post-ganglionic lesion. Okay, that's the key, because something can be done with a post-ganglionic lesion, but it is very difficult to do something with a pre-ganglionic lesion. Okay, and there are 4 or 5 things you need to look at as soon as you see the patient to demonstrate your thinking, to show what you are looking at and how you are approaching it. Okay, and if you see Horner syndrome, which is a pinpoint pupil smaller than the other side, or you have the upper lip drooping, you have mitosis or meiosis, of the pupil, which is very constricted, or there's lots of swelling on that side of the face, or you have an eye which appears sunken, and that will give you a hint, especially if you're looking at a patient that has a brachial plexus palsy, that where the lesion is. It's probably the root, so we call that a pre-ganglionic lesion. Okay, and this is very classical that you will see if you look at the difference between the eyelids. Okay, and it's the short form for that is APEM, which is anhydrosis, would mean lack of sweating. Ptosis would mean that the lid is drooping, which means anophthalmosis, which the eye is sunken, and meiosis, which the pupil is constricted. Okay? If you see a patient with a brachial plexus injury with something like this, all these 4 things, then you know for sure that's a pre-ganglionic problem. Okay? Or it's a supraclavicular injury. Okay? The other thing you will look at is if the person has got winging of scapula. Winging of scapula is supplied by, or how does the scapula get?
Long thoracic nerve, serratus entry. Yeah,
so that's very close to the roots, isn't it? So it's a pre-ganglionic injury. You have winging of scapula. The other nerve that is other muscle that's involved. Sorry. Can we make sure that there's nothing in the background? Otherwise, we get distracted. Like So the most common reason you will get winging of scapula after brachial plexus injury is that they will have a long thoracic problem. What else does show you a preganglionic injury? If you have a winging of scapula, there's another muscle that is also involved in here. What is that? Sorry?
Rhomboids.
What is the nerve to rhomboids?
Dorsal scapular nerve.
Very good. So a ganglionic or preganglionic lesion will give you winging of scapula. Either the long thoracic nerve is gone, or you will have what is called the rhomboids also not working. And if you look at this picture, there are 3 muscles that hold the scapula together. There's the rhomboids, the levator scapulae, and also sometimes in pec minor. But these nerves will tell you that it is a preganglionic lesion if you see somebody who has winging of scapula. So this is another sign that you will keep an eye on to make sure that this is pre or post ganglionic. So the first thing you looked at is the eye. The second thing you look at is if the scapula is winging or not. Okay, and the third thing you would look at is have a chest X-ray, and what does that tell you?
For any can cause
So
tumor.
elevation of diaphragm due to
Yeah, that
phrenic.
is because of the phrenic nerve, isn't it? And the phrenic nerve also comes very close to the roots. Okay? So we are now coming to features to describe what a preganglionic looks like. The first thing would be that the pupil is pinpoint, is got anhydrosis and ptosis and all that. Second thing is they will have a ringing of the scapula, right? And the third thing is if you look at their chest X-ray, they will have, or if you X-ray them, because chest X-ray is one of the first X-rays you do in the ATLS charges, you will see the diaphragm is elevated on that side, okay? And that means that the phrenic nerve is not working. What is the other, if the phrenic nerve is working, what is the importance of the phrenic nerve working?
Sir, it describes the level of injury, means if cervical 3, 4, 5.
Yeah, but others will also describe that, isn't it? What is the importance of the phrenic nerve is working?
So later on, we can do the neurotization of the
Absolutely.
injured.
You want to know what is wrong with the patient now, but you also want to know what you have left, which you use in the future, like I said. So it is important to know what is working and what is not working. So far, we're deciding what is preganglionic or not. So we have three features already assessed. If a patient has got these three features, we can for sure say this is a preganglionic thing. There are other minor features, okay? If you have a person with a first rib fracture or a person who you have seen with transverse processes of the cervical spine broken, then that's a high suspicion that this person may have a brachial plexus injury or would be likely to have had a brachial plexus injury. And why are these X-rays important? I mean, in what cases and scenario will these X-rays be important?
So associated, to rule out associated fracture of like cervical spine and clavicle.
First rib anyway, and we don't do CT scans of the vertebrae. So why are we doing these X-rays and these CT scans for somebody with a brachial plexus injury? Why should we do these X-rays? So these are people who are unconscious. These are people who are intubated. You know, when you do investigation, you cannot assess brachial plexus in an unconscious person. Well, you can, but if these are associated injuries, that will show you that this person may have had a brachial plexus injuries, especially in an unconscious patient who has had a head injury. So how would you assess for somebody that the nerve is working or not if he's unconscious, a child, or is drunk?
Sir, to evoke potential.
It's a test. What would you do in the A&E?
Sir, reflexes?
Reflexes are a local response, isn't it? There are central control, but there's a very simple thing that once a nerve is gone, it also loses its sympathetic supply, isn't it? So what are features of sympathetic supply for nerve?
So ball pin rolling test or?
Yeah, exactly. They will not have sweating and they will be dry. So that if you roll a pin or a ball pen, then it will be rough to move because there's no sweating or no sensation that allows it to move. And that will tell you in a drunk alcoholic or a child person that one of the nerves gone and we have to figure out where the problem is. Okay, so now we know for a conscious patient, the patient will have ptosis, will have a pinpoint pupil, he will have a scapula that's ringing, and also will have a diaphragm that's moving or not moving. However, in a unconscious patient, you can do associated features such as a first rib fracture, or even the chest diaphragm will be visible in people who are unconscious. We do chest X-ray, or they have transverse processes fractures. This is the most common injury that will lead to brachial plexus, and it is called. If you look at this X-ray, what do you see in this X-ray?
Scapulothoracic dissociation.
What is that?
So this is actually the disruption of articulation between the scapula and thoracic cage.
If you look at this X-ray, you never see. Where's my marker? Can you look at this X-ray? The scapula is separate from the ribs.
Yes, sir.
Okay, so if you're an unconscious patient with an X-ray of the chest showing scapulo-thoracic dissociation, then a brachial plexus injury is present. Okay, so and if you look at the schematic diagram there, not only will you have nerve injury, you will have vascular injury. This becomes an emergency. This is one of the few indications of actually doing a brachial plexus surgery early than late, because normally you make the plexus pretty well before you decide what you want to do with it. So we are coming to a diagnosis of where the problem is, and most commonly the problem with roots. Okay, so we are talking about preganglionic lesions. Okay, so once we've gone to the roots, the next stage there is only one nerve that comes from the trunk, from the upper trunk, and that's the suprascapular nerve.
Yes.
And again, this is important to know for the future. The suprascapular nerve supplies both the supraspinatus and infraspinatus. What you do is for supraspinatus is the stress test, or the supraspinatus test, which is the humerus in 15 degrees of the body, which is a abduction of 15 degrees, which is the line of scapula. And if you point the thumb down and lift it up, or feel for tensioning of the supraspinatus, then you know the suprascapular nerve is working or not. The other one is teres minor, okay, and infraspinatus. You need to know all these three muscles are working, and the reason to know that is this is a branch that comes from the upper trunk, okay, and we need to know this because in the future we may need to use this nerve in the future to get some function to the shoulder, okay? Because there are three things that are vital for brachial plexus injury patients. What are the three functions that we have to bring back?
So shoulder stabilization or abduction, elbow flexion, and hand function, sir.
So hand function is not you can control.
Sir, we will give the priority to the elbow.
First is elbow.
The first priority is elbow, second is hand, and third is shoulder.
No, it's not like that. The first priority is elbow, so you can feed yourself, okay? Because you will have different type of nerve injuries, and most cases will not have the hand involved unless you have a total palsy, like I said. So,
okay.
To the exam answer is there are three priorities. First is flex elbow, so you can feed yourself. Second is abduct your elbow, so you can bring your hand to your mouth. And the third is to get sensation to the T1 area. These are the three important priorities that you have to do in brachial plexus reconstruction surgery, okay? So we have now decided that it was a preganglionic lesion. Now we come into postganglionic lesion. So you want to know whether it's in the trunk or in the divisions or in the cords. So if the scapular nerve is gone, then it is the upper trunk is involved. We cannot predict what's happening to the other two trunks because there are no nerves coming out of it. But if the suprascapular nerve is involved, then the upper trunk is involved. So this is a postganglionic upper trunk part. Okay?
Yes, sir.
So, just let me see if I can get the wires taken out. I don't know why this is writing on top of this. Okay, never mind. Okay, so the next thing is you look at the chords. You want to know which chord is involved. So you have three chords, right? Medial chord and the lateral chord and the posterior chord. Okay, so pec major is an important muscle to tell us whether the medial or lateral chord is involved. Agreed?
Yes.
Yes, sir.
So how would you know that the medial or the lateral chord is gone?
So by assessing the lateral pectoral nerve.
How?
Sir, by the clavicular and the sternal portion of the pectoral.
Sorry, I can't hear you.
Sir, by the clavicular head and also the sternal head.
Absolutely correct. So the sternal head and the clavicular head has different nerve supplies. Okay, so the clavicular head is supplied by the.
Sir, by the lateral.
Yes, the lateral nerve supplies the clavicular nerve. And how would you accept that? You will see atrophy of that part of your pec major, which in a late case or in an early case, what you do is to assess this test, okay, which is adduction against resistance. That will tell you the muscles of the clavicular part of the pec major will become prominent, okay. If it's working, it will become weak or not prominent or wasted if it's not working. So the third thing is the sternoclavicular head, and that's you ask the patient to push against his hip or the examiner's hand, okay? And that's what they do. So now, if the person has the clavicular part intact, so then the lateral cord is intact. If the sternoclavicular part is intact, then the medial cord is intact. So, okay, are you guys with me? So before we decided ganglionic and postganglionic, yeah. So now that we know what is preganglionic, and preganglionic is okay, it doesn't have ptosis, it doesn't have the winging of the scapula, it doesn't have diaphragm, so we now know it's postganglionic lesion. Okay, and if it's a postganglionic lesion, we need to know what the level it is. Yes, exactly. So we know that the supraspinatus and infraspinatus is working. So we know that one of the divisions is the only one that comes from it is working. So now we know which cord is involved. So if you come down to the cord, you need to know medial, lateral, and posterior. Okay, the lateral is the sternal part of the clavicular part of the pec major, and the other one is the medial part of the pec. Is tell you whether it's a lateral or a medial cord. Okay, so we happy so far?
Yes,
Yes,
sir.
sir.
Okay,
Yes, sir.
so now there is only one cord left, posterior cord. Yeah.
Yes.
So
Yes,
what
sir.
branch from the posterior cord comes, which you can test to assess whether the posterior cord is involved or not?
Axillary nerves.
Very good. And what does that?
Axillary radial nerves.
Yeah, lower down, but at that particular level, posteriorly, what is coming out?
So axillary is applying to the deltoid muscle.
Deltoid.
Okay, and but one particular type of nerve is coming out from there that you can specifically tell you that is coming from the divisions at the time, the posterior division, and that's the subscapularis. Okay, the upper and lower subscapular nerves come from there.
Yes, sir.
So if you do a belly press sign, like you assess for the subscapularis, if it's working, then the posterior cord is working. It may be divided future on, but the level you want to know is whether it's at that level where the cords are being formed, or it is the level beyond it. Okay, so lateral, medial, and posterior cord. Lateral cord, we know it is pec major. So pec major is an important muscle, and if it's the clavicular part, then it's a lateral cord. If it's the sternal part, then it's a medial cord. And if the subscapula is not working, then it's a posterior cord. It's at that level. Hang on, let's go back again. So you need to be clear on this, yeah? See, if you look at it, suprascapular nerve is the only one that comes from the superior division, yeah? Can you see that, yeah? So that's why we assessed it for the infraspinatus. When you come to the divisions, there are nothing coming out of it, but when you come to the cord, there's only one branch that comes out of the lateral and the pectoral nerve. And also you see from the posterior cord, you will see that the upper subscapular and the lower subscapular nerve is coming. That is that's the test you have to do for the the Napoleon signs or whatever for the nerve. Can you understand? That's why we're testing that. So we know from the cord we have a pec major supply coming from here, and we have a medial pectoral nerve coming from the medial side, and then we have the posterior cord. The posterior cord, before it gives branches, supplies the subscapularis. Can you see this branch here? Yeah.
Yes, sir.
If you have an injury at this level, then you need to know whether the posterior cord is injured at this level or beyond it. So if the nerve supply to the subscapularis is intact, then this is working. Are you guys with me?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
It's not difficult. It's very methodical if you understand what you're looking for at the branches. Okay. So
Yes.
Yes, sir.
we're happy so far, yeah. So I need
Yes, sir.
to
Yes.
repeat now. If it's a preganglionic lesion in a patient when you're examining, what would you see?
The Horner syndrome, first of all.
Yes.
Winging of scapula and elevation of diaphragm.
Very good. So if you don't see this, then it's not a preganglionic lesion. Okay.
It's a postganglionic.
Yes.
Okay. So now the next part of the brachial plexus is
Trunk.
Yes. So there's only one branch coming from that part. What was that?
Yes. So this is trunk.
Yeah. So what branch is coming from there?
So nerve to subscapula.
Suprascapular.
What? Sorry.
Trunk. The trunk से suprascapular.
Yes. So we will assess the rotator cuff. The supraspinatus and infraspinatus. Now, if that is working, then the superior trunk is okay. Okay. So if now you have no ptosis, no winging of scapula, and you have the rotator cuff working, then you have. So the injury is beyond the trunks now. Okay. Are you with me so far?
Yes, sir.
Yes, sir.
Okay. So then.
the upper hand surgeon.
Sir, can you pause all the mics, sir? Someone is talking behind.
Brachial plexus injury.
Sir, excuse me, sir. Don't we see the long thoracic?
Okay, so you come back here. So we now know it's a post-ganglionic lesion. In the post-ganglionic lesion, it is not coming from the trunk, and it is not coming. We need to know whether it's coming from the cords. In the cord, you need to know whether it's a lateral, medial, or posterior. For the
Are you listening me?
sorry.
Are you listening me?
Yes.
What about the long thoracic nerve for the winging of scapula? Serratus anterior.
As already told by the sir that it supplies the rhomboids.
Yes, so we if it's a preganglionic lesion, the long thoracic is here. That we'll find out. We just discussed that it's you have a winging of scapula, isn't it? Or there's a nerve to the phrenic nerve to the diaphragm. So if you have a preganglionic lesion, then these will present. If you don't have these lesions, then you would need to know whether it's coming from the trunks, and there's only one nerve coming from the trunk, and it's the suprascapular nerve to the cuff muscles. So if you have no ptosis, no winging of scapula, diaphragm is okay, your cuff is fine, so then your division is beyond that. So from the divisions, they will become cords, and the cords will then become lateral, medial, and posterior cord. So if you assess the pec major, and the pec major is not functioning either at the clavicular level or the sternocostal level, then you will know whether it's a lateral or medial nerve. And if they both are working, but your subscapularis is not working, then it's a posterior cord. Okay, simple with me for so far? You need to understand this bit. If you understand this, you need to know where the rest of your injury is.
Yes, sir. So we can go ahead.
Okay, so the next thing to look at is the branches. Okay, there are zillions of branches, but you need to remember the 5 major ones. Okay?
Okay.
We're all happy so far, yeah? Because I don't want to go forward unless you're all happy with where we are.
Yes, sir.
Yes, sir.
We will revise it at the end, okay? And we might have to do it again some other time, but this is something everybody struggles. But it's not difficult to make sense of it as long as you go systematically, okay? Okay, so the next branch we want to look at is the branches now. We've done the roots, we've done the divisions, we've done the cords, and now we want to look at the branches. Terminal branches you will have is the axillary nerve. Okay, so the axillary nerves come from C, 5, and 6, and what function do you get out of the axillary nerve?
Deltoid supply.
Okay.
Abduction.
Tricep supply.
So far we've checked.
Tricep supply.
If everything is working, but the deltoid is not working, then we know that the axillary nerve is in trouble. Okay?
Yes, sir.
Okay.
So deltoid is supplied by axillary nerve.
So what does the deltoid do?
Deltoid is in trouble.
Abduction.
Initial abduction.
90 degrees.
God, no. So the deltoid does everything. It does forward flexion, it does abduction, and it does extension. Correct?
Abduction.
If the socket, if the ball is in the socket of the shoulder, then the deltoid will do forward flexion, abduction, and extension. Yes?
Because deltoid has 3 fibers: anterior, lateral, and the posterior.
Absolutely.
So anterior flexion, posterior causes the extension, and the lateral one for the abduction.
So don't forget this in the exam or in the heat of the exam, that the deltoid doesn't do initial abduction. It does forward flexion, it does abduction, it does extension. All 3 muscles because of the tripenate muscle. And to top it all, it has given you an opportunity or a window to assess it even better by looking at the Sargent's patch. There is a small patch here, okay? And you lose sensation because the sensory branch also comes out as part of the deltoid supply, yeah? And so if you have weak forward flexion, abduction, or extension, and you have a patch that is not working properly, then you know that the deltoid is not working properly.
Gotcha, yeah.
I'm not sure why we're having so many...
Yes.
Distortion.
No, this nerves and rights, I don't understand why we have so many clear.
But sir, abduction is majorly affected because the flexion is done by other muscles also.
Yes. That is why you need to look at the sensation. You need to look at the sensory patch, yeah?
Yeah.
Okay.
Regimen Bay area.
So we more focus on the abduction only.
You can, but for completeness, if I'm your examiner and you tell me that adduction is lost, then I'm not happy because of the triponate muscle. You have to tell me all three things, and you tell me all these strengths plus the sensory badge is missing. Therefore, the deltoid muscle axillary nerve is not working. Agreed?
Agreed.
Yeah. Okay. Good. So the next nerve we were looking at. No, it doesn't want to work. Oh, there you go. Is the musculocutaneous nerve. And it is a nerve that predominantly flexes at the elbow, yeah?
Yes.
Yes.
Supplies the biceps.
Okay,
Biceps
so from the branches, we have looked at the axillary nerve independently, and we have assessed in independent. We know it's C5-6, and we also know the musculocutaneous nerve you will assess for biceps flexion, okay? And then the third nerve is the radial nerve, which is a very complex nerve, okay? It has problems at 3 different levels. Can you tell me?
Yes.
Go on then.
Yes, sir.
So,
One is very high level.
yes.
Second one high level. Third one is at the low level. And some book used to write as a very low level too.
Sir,
So that is like a child telling me, you are an orthopedic surgeon doing an exam, so you have to be very specific. So you have to have high level
Very
injury.
high, and low level.
So high level, then in the groove at the elbow, 3 different places. Okay, these are 3 vulnerable places where it is vulnerable to injury. So you have a high level injury which is coming from the cords where the branches are coming, or you have it in the groove, or you have it at the elbow. Okay, so the function of the triceps will be absent in all 3, or not.
Sir, triceps will be very high.
Actually,
yeah, it has to be a very high lesion for the triceps to go. Absolutely correct. So
Exactly.
if it is in the groove, what would be spared?
So the triceps.
Patient will to extend its high level energy.
So at high level, the tricep is gone. Everything is gone, yeah? So if
Yes.
it's at the groove, what will be going?
Wrist extension.
Unable to
Extension and finger extension.
Long extensors, sir. Long extensors.
Which ones are those?
ACL and ACL.
Yes. So if you're gone at the groove, right, then you will have either ECRB or brachioradialis working. So you have to send ECRB at that level because it's in the groove. So the triceps may be working, but ECRB may not be working if it's at the groove, so we know what level it is then, okay? And if it's at the elbow or beyond the elbow, then you get what is called a wrist drop, okay?
Yes, sir.
Wrist extension will be affected.
So exactly, so you need to know where the problem of the radial nerve is. It's not as simple as the radial nerve will have no triceps function. If it's higher up, the triceps and everything will be gone. If it's at the groove, then ECRB will be spared. And if it is going beyond the groove into the wrist, then you will have a wrist drop. So what's a paradox? Ulnar paradox.
When the radial nerve, when the wrist extends towards the ulna.
Yeah, so distal. The higher problem means that there is unopposed action of some certain muscles. Okay, we'll come to that. So what are you looking at, or what do we call this finger?
Index finger.
Index pointing finger, yeah?
Pointing sign.
Exactly, yeah. So this is the median nerve. In England or in Europe, they call it the Benedict sign. You know why they call it the Benedict sign?
Hand of benediction, the index finger is pointing upward.
Yeah. When you go to Rome, when you're in the church, the Pope blesses you with his finger. That's why it's called the Benedict finger, yeah?
Yes.
Okay, so the median nerve on its own involvement will give you a pointing finger sign, yeah? And the ulnar nerve will give you a clawing of the ulnar side. And if it's a very distal, distal lesion, then you will have wasting and intracranial gone. And that's what the question was at the time. What is the ulnar paradox?
The more distal the lesion, deformity will be grosser.
Sir, more proximal the lesion, the less will be the flexion. The more distal lesion, the more flexion present.
So the more distal the lesion, the more the deformity is, purely because
when the lesion is proximal.
Okay.
When the lesion is proximal,
then the deformity will be less because the FDP is spared. In the in the lower one. That's why the deformity is there. But in the upper lesion, the FDP is gone. That's why this.
Yeah, because there are some muscles that will have unopposed action, and therefore the deformity becomes less. Correct? Okay, so this is a very important slide to understand. Okay, if you understand this, you've got the crux of the brachial plexus. Okay, so you have clawing of the index fingers and middle finger and clawing of the little finger. Okay, so you must understand that in a median nerve injury, if it is distal, they cannot extend their index and middle finger. Okay.
Right, sir.
Okay, but if it's a proximal ulnar injury, then they cannot flex the fourth and fifth finger. So in this picture, you cannot extend the finger, and in here, you cannot flex the little finger. It looks exactly the same, but you have to assess them, clinically examine them to make sure what is what. With me?
Yes, sir.
Okay, in the same way, if you have a distal ulnar nerve, they cannot extend their fingers, whereas if you have a proximal median nerve injury, they cannot flex these two fingers. So this one can move, this one can't move. Here, this one cannot move, but these can. Do you understand that?
Yes, sir.
So actually, the flexion of the intraphalangeal joint is weakened, which reduces the claw-like appearance of hand.
Yes.
So this occurs because of, and when there occurs the re-innervation of the ulnar nerve at a high lesion, then deformity gets worse because the flexor heterum profundus is re-innervated.
That's correct.
Recover.
Okay, good. So why do we need to assess the spinal accessory nerve, which is not part of the brachial plexus?
Sir, it is a donor muscle.
It's a what?
A donor muscle for shoulder abduction.
No, not muscle, but nerve.
Exactly. You need to know what the spinal accessory nerve is doing and it's functioning. You can use it in the future to use it as a donor. Okay. So when you're doing a brachial plexus examination, when you finish your brachial plexus examination, then you need to assess to show that to the examiner that you know what you're doing is. He will assess a spinal accessory nerve to make sure that if in the future, if you want a donor, you can have a nerve that you can transfer or neurotonize. Okay. So I need one of you now who thinks that he knows what we've just discussed completely to tell me from start to begin. We're not finished, but can you tell me what level the injury is if you're assessing a brachial plexus? So can one of you? I don't want all of you to talk at the same time. I want one of you to volunteer. If you tell me what your name, then I'll let you answer the question. Who wants to speak? So now if you speak, it's okay. We don't get angry, we don't lose many marks, and we don't fail exams. If you don't speak now, you won't speak it in the exam, and therefore you will be in trouble then.
So
can you repeat the question?
So who's may I? Can you either
so may I?
Yeah,
can you repeat the question?
Salman.
Yeah, sir.
Okay, so go on from the beginning now. If somebody comes to a brachial plexus injury, how will you assess what level it is?
Sir, I would like to first assess if it is pre-ganglionic or post-ganglionic, or it is a PAN. For PAN, sir, lesion, I would like to assess the Horner syndrome. In sir, pre and post ganglionic. For pre-ganglionic, I would like to assess the serratus anterior, the rhomboids, and also the phrenic nerve.
Very good.
Sir,
supraclavicular lesions. Okay.
Yes, sir.
Good. So now, infraclavicular lesion. What will you do next?
Sir, for infraclavicular lesion, I would like to assess the suprascapular and infrascapular muscle. This will be my division.
It's the only nerve that is coming from the divisions, yeah?
Yes, sir.
Good. Next.
And for the cord lesion,
next,
for the cord, I would like to assess the scapularis.
C5, C6 root injury will be assessed also.
Okay, so I don't want you to complicate yourself by C5, 6 and this on the concept. All I want you to tell me where the level of the injury is, because if you're assessing the nerves, the roots are the same. You need to tell me.
Root injury is root lesions.
Okay.
Sir, for cord, I would like to assess the subscapularis.
Okay.
And also the pectoris, also the pectoris.
The cord, that is a lateral cord, medial cord, and posterior cord.
Yes, sir.
Okay, so for the lateral and medial cord, you will assess the pec major, And if the clavicular bit is gone, it's lateral. If the sternocostal bit is gone, it's medial. And if the subscapularis is gone, then it's a posterior cord injury. Okay?
Right, sir.
So far, so good. Don't confuse yourself with nerve roots. This is C5 because all of them are shared by various nerves. So it doesn't help you what root you're looking at. You're looking at what the level of the injury is before you can plan management. Okay, so the level of the injury is preganglionic, postganglionic, which is supraclavicular, then infraclavicular. Infraclavicular, you need to know which is where it's coming. So we've come to the cord. From up to the cord level, it is easy and it's easily rememberable if you just go systematically. Okay, you do this in the exam, the examiner can't fail you because you are telling him exactly what to look for. However, if you start doing C2, C3, C4, sorry, C5, 6, 7, and 6, 7, T1, you will confuse yourself and your examiner. Okay, everybody happy so far?
Yes, sir.
Okay, so now one of you, not Salman, but somebody else tells me what are you looking for in branches? Which branch is gone?
Regularly a bottle go child.
Hello.
Yeah, hi. I mean, guys.
Yeah, sir. It's Rafiq.
Sorry?
Rafiq.
Good, good. You tell me branches then, Rafiq.
Okay, sir. Sir, branches of the all the cords or the posterior cord?
So there are 5 branches, isn't it, altogether?
Yes, sir.
Okay, 5
branches. 5 branches. I will start from the axillary nerve. For that, I will check the deltoid, forward flexion, extension, and the abduction, as well as sensation over the regimental base area.
Okay, so when you're assessing the brachial plexus, all you want to know is what nerve is not working. Because if somebody tells you roots or different branches of that, you can't help. You can't do anything with it. But if you know which one is not working, you can. We'll come to this later, how you can repair this. So we've looked at the axillary nerve, one of them. What are the other 4?
Yes, sir. Then I would look for the ulnar nerve.
Okay.
And
the ulnar nerve is a higher level or lower level?
Individual muscles function and sensation, motor and sensory function both.
Yes, sir. I will start from the it's ulnar part of the flexor digitorum profundus and the small muscles of the hand for the ulnar nerve, especially the those which causing the adduction, the interosseous muscles, and for the median nerve, I would check the lateral side of the FDP, the pronation, and the.
So in the exam, the examiner doesn't have time and you don't have time. So you need to make a short version of presentation to tell them. So for the axillary nerve, we look for the deltoid function, yeah? For the median nerve, we look at the pointing sign. For the ulnar nerve, we look at a claw-hand or claw-hand paradox, okay? And for the radial nerve?
Sir, for the radial nerve, manage the wrist drop.
Wrist extension.
Exactly. So in the exam, tell them that if the person deltoid is not working, I think the axillary nerve is not working. If the person has got a pointing finger, the median nerve is not working. If the person has got a wrist drop, then the radial nerve is not working. If the person has got a claw hand, then the ulnar nerve is not working. Okay. Then the examiner may ask you to look at various muscles and various tests you can do. But we are first of all finding out where the problem is before we can go and localize which part and what nerve is not working. Correct?
Okay.
So if you keep describing one muscle and one nerve with 5 different muscles, then the examiner gets bored and it doesn't give you the opportunity to show you what else do you know. So you need to do the short, sharp answers so that you can show him that you know. And if he wants to quiz you more, then that's his choice then. Agreed?
Okay.
So we have now nerves that we're okay with the fact that if somebody shows a brachial plexus, then we know where the level of the injury is, whether it's a preganglionic or postganglionic. Whether it's infraclavicular or supraclavicular, whether it's in the divisions or in the cords, which cord is involved and what are the branches doing. We happy with this?
Yes, sir.
Should we move on?
Yes, sir.
Okay. So the next thing you need to know to show the exam is to know the MRC grading. Okay, but you need to know the MRC grading to qualify how much of motor function is not working. Okay?
Okay.
So the next thing you do then is that if you feel that the muscle is not working at all, you need to change the plane to understand if you take the gravity out of it, does it still work or not? Or if it's working fine, is gravity helping it? So you need to change the plane once you assess a grading of the MRC, and then come back and revise your grading. Okay?
Okay.
In the exam, start proximally, work distally. Okay? Have a method. You just don't pick different things different ways. Just start proximally and work distally. Okay? The next thing is brachial plexus have got two types of injuries. They're predominantly closed and open. Okay, so closed injury are mostly from falls and tractions, sometimes radiation, sometimes tumor, and sometimes after surgery. Okay, the open injuries are always gunshots and stabbings, and during a orthopedic related procedure when you've done something and you're looking during an operation, you feel that you've torn a nerve or cut a nerve or pulled a nerve, and that's the open. So most common closed is traction, most common open is gunshot and stabbings. Okay?
Okay.
So if you look at this particular picture, motor car accidents are 70% of brachial plexus in Europe. I'm sure it is more common in Pakistan, including to penetrating injuries. It is not a traction injury. Am I wrong? Am I right?
Yes, sir.
So we can understand motor car accidents are not the major cause of brachial plexus. It's gunshots and stabbings. Or is it the same? I don't know. Okay.
Yes, you are right.
Okay. So these are some pictures to help you remember that you can have traction injury, or you can have injuries of traction which will cause, if the neck's moving, then the upper trunk is gone. If the arm is moving, then the lower trunk is gone. Yeah. You just need to remember this picture to help you. Okay. Or these are the type of falls. So in obstetrics, the commonest upper brachial plexus is when the patient is presenting normal and you pull him out. If it's a breech presentation, it will be lower brachial plexus injuries. If you're hanging from a branch, it will be a lower brachial plexus injury. And if you're falling on your shoulder, it's going to be an upper brachial plexus injury. These are things that you can assess from the history before you examine the patient that will give you a hint of where we are looking at. Remember, if you look at a patient, while you're taking the history, make sure you look at the upper limb to see whether his hand is functioning or not, or is rotated or not. It will tell you whether it's a higher or lower root problem, yeah? So the common injuries present in brachial plexus, we've done the examination. I just want to complete the subject on how to approach and operating on these, yeah? So the common injuries associated with brachial plexus injuries is, especially the patient's unconscious, is the proximal humerus, the scapula, rib fractures, clavicle fractures, transverse processual, and also the dissociation of the scapula. Okay, we've discussed that already. So in broad terms, we describe them as the upper plexus injuries, lower plexus injuries, and the Lifford classification, which gives us the level of injury which we've just discussed. Okay. So we've discussed this pre-ganglionic, post-ganglionic injuries, supraclavicular, infraclavicular. Okay, and this is something to remember with. So we were all talking about roots, isn't it? At the time, we wanted to find the level. Now the roots is important. If you found the level, you want to know which root is not working. So you want to know if it's a C5. So what does a C5 do? So the C5, easiest thing to assess for a C5 is
shoulder abduction.
Deltoid, yeah? And sensation is the lateral part of the arm.
Upper lateral part of the arm.
Yeah, C6.
Lateral part of the forearm.
Yeah, and wrist extensors.
Yes, up the thumb.
C7 is triceps.
Yes.
Yeah, and it's posteriorly is the sensation is or coming to the finger, the right middle finger. And C8 is little finger, ring finger sensation, and it's finger flexors. And T1
middle part of the forearm also.
Sometimes, not always, yeah. And T1
middle part of the forearm and middle part of the upper arm.
I don't think so. C8 goes to the upper arm. It's the T1 that goes up there.
It's T1. I'm talking about T1.
T1.
Yeah.
Yes. Okay. And finger. So you need to know or have this picture somewhere stuck into your library or whatever, so that when you look at it, you know it's 5, 6, 7, 8 or T1. Okay. So now we have done two things. We know what root is working or not working, and we also know what is the level of the injury. Okay. So in a brachial plexus, we have done two important things. We have found out where the level of the injury is and which roots are involved in it. Okay, agreed?
Okay.
So then you can do these individually. We've all gone through this, what we just discussed, like, okay, C5, C6, C7, C8, and T1. So are there 8 cervical vertebrae? We only have 7 cervical vertebrae, isn't it? So what's the 8 doing?
We have 7 cervical vertebrae, but 8
cervical are 8.
Nerves 8 hai or vertebrae 7 hai.
Yeah, that's because one comes above it and one comes below it, isn't it? Like, it doesn't come from the same level. Okay, good. Okay, so we've done that. So there are words that you must remember if an MCQ is asked or somebody talks to you. Burner, stingers. Do you know what that means? So when you are playing rugby or you're playing football or you have a fall with your arm completely and totally hyper-abducted, in that case, the nerve may not have been stretched or torn or damaged, but they have been transiently gone into a position because of the elasticity of the nerve. It has gone back to its shape, but because it's been pulled to a certain level, you get pins and needles and you get sharp shooting pain. They're called burners and stingers, which means the brachial plexus itself is intact, but it went to an extreme in its plastic limit where it stretched it and gone back to normal again. Are you with me?
Yes, sir.
Do you remember that stress-strain curve? In basics orthopedics, stress-strain curve?
Yes, sir.
There's an elastic limit and there's a plastic limit. Do you understand that?
Yes, sir.
So if you go to the elastic limit, you have not done permanent damage, but you stretch it so much that your nerve does not like it, so it presents itself with a stinging pain or a burning pain, the sensation of the nerve that you've stretched. If you cross your plastic limit, then you've damaged it, it won't go back to normal again, and you will have a brachial plexus problem. Okay, what is Parsonage-Turner syndrome?
Sir, it is a post-viral infection.
So it's an infective process, but what does it different from brachial plexus injury and Parsonage-Turner syndrome? What's the difference?
Parsonage-Turner syndrome, there is bilateral AIN.
It is bilateral.
Talking at the same time. So Parsonage-Turner syndrome is an infective problem. It has got a nerve problems that are temporary and transient. It is very, very painful, severely painful. However, it is not anatomical. Do you understand by that? So if you are looking at a problem which you think is coming from C2, C7, C8, but then it will have patches. It won't have normal areas, but it will have abnormal areas in the middle. So it does not follow anatomy. That's the difference between brachial plexus injury and Parsonage-Turner syndrome. It's an infective process, severe pain, temporary, transient, however, does not follow anatomy. So you may have wasting and weakness, but it does not follow a pattern of a nerve. Okay? That is the easiest way to differentiate it. It does not follow anatomy. If a nerve is gone, a particular nerve is gone, and it will be gone completely, its sensation and motor branches will go away, and you'll have no function on that particular nerve. However, in Parsonage-Turner syndrome, it does not follow anatomy. It is not got any pattern. It will be patchy. Some of it will be working, and some of it is not going to be working. And that's a classical feature of infection. Okay?
Right.
Yes, no. Everybody's gone quiet.
No. Yes,
sir, isn't the Parsonage-Turner syndrome is not related to bilateral anterior intraosseous nerve of the median nerve?
No. It's an infection part of the brachial plexus, and it involves any nerve in the whole of the brachial plexus, but it is not anatomical. It is all patchy.
Right, sir.
Okay. So again, there is a classification. I'm not sure whether you need to know this or not, but if the exam MCQ comes with a NARCIS classification, that's a brachial plexus classification, which tells you which group is involved and where there is recovery or not. Okay. So there's 1, 2, 3, and 4. C5 and 6, i.e. top, middle, the whole of it, or the whole of it with Horner syndrome, which is a preganglionic. Okay. And most of the type 1 will recover. So the higher the lesion is, the better the prognosis. And most of the ones with poor or no hand function will have a very bad prognosis. Okay, so that's all important. So what's Erbs point? Do you know what's an Erbs point? That's an MCQ question, yeah? What's an Erbs point?
Sir, it is actually a point in the brachial plexus where if the injury occurs, causes the Erbs palsy.
So it is got an importance because it's a lot of nerves are joining together at that particular point. It comes from C5 and 6, and if you look at it, there's a lot of nerves coming out. So the nerve to subclavius is involved, and various other structures are involved in it. Therefore, it is a particular point, and you can ultrasound scan it in this triangle here. The reason why it is important is it's a confluation or a joining of a lot of nerves together. So when you have an injury in that particular area, you have a lot of features attached to it, and it's called the Erbs point. Okay, and you're absolutely correct. If you have an injury around the Erbs point, then you have what is called an Erbs palsy. And the easiest way to remember that is you have fibers, which is flexion of the elbow is gone, abduction of the shoulder is gone, external rotation of the shoulder is gone, and supination of the forearm is gone. Okay? And they look like, what is the word they use?
Waiter's tip?
Waiter's tip.
Waiter's tip, policeman's tip, or beggar's hand?
Policeman's tip, yes.
So the waiter and policeman is far more explained because they're hiding, they don't want you to see, but they're putting the hand at the back to get some money off you, like, isn't it? It may be called waiter's tip, but it's more often called as a policeman's hand, yeah? But anyway, so this is the Erbs palsy, which has got Horner's syndrome, which has got a lack of flexion of the elbow, which has got lack of abduction of the shoulder, which is externally rotated. External rotation is gone, and supination of the forearm is absent. Okay, and it's mostly common in children because of the birth problems in normal delivery. Okay, and the other one to match this is the Klumpke's. Okay, and the Klumpke's is a lower CAT1 problem, and you end up with a claw hand. But this is different from ulnar nerve problem. How?
Sir, only the lower trunks are involved.
Yeah, okay, but how would you know that this is not an ulnar nerve isolated problem, but it's a Klumpke's?
Sir, only the hand is involved by
the deficit is more likely limited to up to the hand.
Yeah, so it's a root problem, isn't it? It's a preganglionic problem, so it will have all the features of preganglionic features, whereas an ulnar nerve on its own will not have all these features, correct?
Okay. Yes, sir.
The difference is the Klumpke's is a preganglionic problem.
There will be more clying of the hand.
The ulnar nerve is a more distal problem. So with the Klumpke's, if you're looking at preganglionic, what else would you have? You'll have Horner syndrome. You will not have Horner syndrome in a ulnar nerve, correct?
Right, sir. Right.
But it is very rare. It is very rare. But you need to know that whether it's the root or whether it's a
rare in Klumpke's.
Yeah. Okay. So remember this slide. The difference between Klumpke and Erbs is that one is a upward force injury. One is a lateral traction injury. The tear of the lower trunk is Klumpke's, and a tear of the upper trunk is Erbs. And a clawing of the hand is Klumpke, and a waiter's tip arm is Erbs. So this is how to distinguish a hand in a short case. Okay. So is it enough? Should we continue, or should we come back another time? Are you able to learn any more, or you've just got?
No, continue, sir.
It's enough for today, I think.
No, sir. I think we will forget the previous lecture by the time if we leave here.
I can do it again in some other time, because you don't want to. After a certain time, you cannot remember anything. Okay, so today it's important. We have learned what's a preganglionic and what's a postganglionic lesion. We have also learned what is a supraclavicular and what's an infraclavicular lesion. We have also learned what to assess different part of the brachial plexus. So we know what is coming from the division, what is coming from the cords, and what is coming from the branches. Okay?
Right, sir.
You will not get into trouble in the exam now after this, isn't it?
Yes.
Yeah, but you just got into trouble. I asked you what was the difference between a Klumpke's and an ulnar nerve.
So one thing I want to ask from you.
Yeah.
Which nerve is most commonly damaged in the in beats during supracondylar fracture of the humerus? It's written in radial nerve. Or
Depends on where the
median
fracture
nerve?
is. So if it's a traction injury and it's the axillary nerve, if it's in the groove, then it's a radial nerve. Okay, so it depends where your injury is, and the radial nerve groove is called something. What's the name for that?
So a common question, mostly asked in MCQ, is which nerve is
All
most
Stein
frequently
Lewis.
damaged in the supracondylar fracture of the humerus? So it's radial or median
Okay.
nerve?
So in supracondylar fractures, all nerves get damaged. All three nerves get damaged. The median nerves get damaged. The radial nerves get damaged. The ulnar nerve get damaged. Okay.
Which nerve is most commonly damaged?
The median nerve is the commonest nerve that gets damaged in supracondylar fractures. The commonest, but
But
also
in books it's the radial nerve. But in books it's mentioned the radial nerve.
Yeah, no, the radial nerve is not as much damaged as the median nerve is. They're nearly the same. They're 22%, 23%, or something like that. All three nerves get damaged. So it's a bad MCQ question. Okay.
Basically, the good MCQ question.
Sorry.
Is so basically the nerve that are injured according to the mechanism of supracondylar. If it's
Absolutely
extension
correct.
type,
Absolutely
then
correct.
the most common is anterior introduces. If it's flexion type, then most common ulnar, and second most common is radial nerve. So this is the basic distribution that I read somewhere.
Absolutely correct. However, if you look at
actually whenever the MCQ comes, there's never the scenario given. This is just only line given that which nerve is most commonly damaged. That's why I asked.
Yeah,
so my
it's a bad
experience is
MCQ
also
question.
median
So
nerve.
this MCQ question is very difficult because it cannot be proven with evidence-based medicine. And unfortunately, in the exams, you cannot fight the MCQs because whoever has done the MCQs has also given you the key. But it's a bad MCQ. It's a bad MCQ. You're right. You look at flexion injuries. So what is the commonest nerve that will go with a flexion, which is the most common thing? So what nerves go if you have a flexion type of supracondylar fracture?
Median nerve.
Median nerve. Median, guys. Median.
No, sorry, ulnar nerve. Sorry.
So remember this. Remember this is the anterior interosseous nerve that is damaged in a supracondylar type of injury, which is inflection, which is common. That is what evidence suggests. However, it depends on what the examiner is thinking. So I think that's a bad MCQ question. There is no way that this question is something that everybody will agree on. But unfortunately, you are doing the exam. I'm not. I've done my exams a long time ago, so I don't have to worry about it, but you guys have to. Okay, so happy. So I've really worked hard to teach you brachial plexus because I don't do brachial plexus. It has taken me 3 days. I'm grateful that all of you have turned, or most of you, you've got 21 people turned up today, which is amazing because normally we have 3 people. Okay, so I will come back again during the week somewhere, or maybe next Sunday, and we'll do this again, and then we'll go beyond to how we manage and treat these and what transfers we can do. But before we do that, guys, remember, you have to revise. Okay, you have to know what is a preganglionic, what is a postganglionic lesion. You'll have to look at scars. You then have to assess that person, where it's coming from, the division, which part of the cord is involved, and what branch is involved in it. Okay, so if you know all that, then brachial plexus is not difficult.
Yes, sir.
I will call it a day. I will have a video, hopefully, from what we've done today, and I'll post it on the forum, so you can keep looking at it and revising it. Okay, but you must all thank me because I don't do brachial plexus, and I went the whole last week to read brachial plexus so I could teach you guys.
Yes, sir. Highly appreciate it.
Okay.
Thank you so much.
Thank you so much.
Thank you, sir, for your